all of our attention and energy and money is going towards the wrong area. Patients get one doctor's office visit a year. They get one blood pressure check. They get one set of labs. And then when a crisis happens, we're monitoring them 24/7.
Was there a moment for you when you sort of realized that traditional healthcare isn't addressing a lot of what matters most for people's health?
We had this one lady in her 60s, and she had a cholesterol panel that was within the reference range. Her 10-year risk category for cardiovascular disease was low. We ended up doing a carotid ultrasound on her and found some plaque. That's what the New York Times article was really pointing out. These patients got these false negatives, got a false sense of confidence, and pushed off routine cancer screenings. People out here in this field that are doing dangerous medicine. I admitted a lady in her 80s. Her doctor had her at the hormones of a 25-year-old. I don't think that the hormones of a 25-year-old is really for longevity. It's to have babies, and that 80-year-old woman was not going to have babies again.
Hey everyone, welcome to the Optispan podcast. I am super excited today to welcome Dr. Nicki Byrne into the studio. Nicki is our clinical director. You may recognize her from one of our prior episodes. Today we're going to talk all about Nicki's background, how she got into Healthspan Medicine, and what we do here at Optispan. But before we get into the easy stuff, we have a difficult topic that we have to talk about. We've both been had our wardrobes commented on this morning. Apparently I wear a black shirt too often, and you wear stripes. So
stripes is not a good look.
I'm just wondering how you feel about that before we get into the easy conversations.
I feel pretty strong about it. I think stripes are a good look.
I agree. I think Nicki looks great. I know I've got work to do, but I'm a work in progress, as you all know. So anyways, thanks for sitting down. This will be the first of many such conversations, I'm sure. And I thought to start, you came from what I would call traditional medicine, or what we've sometimes called reactive disease care on the podcast before. Not that long ago. It's only been a couple of years now since you made the transition out. Was there a moment for you when you sort of realized that traditional healthcare isn't addressing a lot of what matters most for people's health?
Yeah, in terms of that, I don't think there was a moment. I can remember a moment of when I decided to leave. But I think it was just very obvious quickly as you're working in the hospital that all of our attention and energy and money is going towards the wrong area. Patients get one doctor's office visit a year. They get one blood pressure check. They get one set of labs. And then when a crisis happens, we're monitoring them 24/7. We're getting at least daily labs. We're getting them up with PT and finally getting people moving. And we're putting, an inordinate amount of money to get them into a skilled nursing facility so they can get home. And why are we doing all of that when upstream of this, you get that one annual appointment? The moment I decided to leave, though, I think I spoke about this on the other podcast, so forgive me if I'm repetitive, but I admitted a lady in her 80s. She was super active. She was hiking and she was swimming every day, and she came in for a devastating stroke. And as I'm going through her history, she's telling me about this longevity physician that she sees. And he had her on 2 pages of supplements. Like, that is just a setup for drug-drug interactions and all sorts of things. He also had this idea that she was super proud of, was that her doctor had her at the hormones of a 25-year-old, which, one, doesn't really make sense because a 25-year-old woman has such big fluctuations every month. So I don't know what the normal was there to be of a 25-year-old. But I don't think that the hormones of a 25-year-old is really for longevity. It's to have babies. And that 80-year-old woman was not going to have babies again. And so I just felt like there are people out here in this field that are doing dangerous medicine and that I could offer something much more.
So it's a combination of seeing challenges with the traditional healthcare system and some challenges with the longevity medicine ecosystem. Well, great. Well, I'm thrilled that you decided to join us in this endeavor. When you tell people now what you do, the clinic director at Optispan, what do they assume that you do, and how does that differ from what you actually do?
Yeah, I think the facial expressions that I get from most people seem like I'm a snake oil salesman. So in practice, I usually say I'm a physician working in preventative care. And then if I'm sitting down with someone and having a longer discussion, I'll kind of explain our philosophy and how we're really trying to optimize lifestyle levers, how we're being aggressive with known medical physiology, and not just here's something completely untested. We're going to put it in your IV and what I think a lot of people think of as longevity or healthspan medicine.
And you recently had a chance to speak at the Puget Sound Business Journal Healthcare Leadership Awards. One of the things you said was, if we prevent the initial crisis, can we prevent the decline that follows? What does preventing that first crisis really look like in practice?
Well, I think I'll go back to what a little bit more about the crisis and what follows first is, so people tend to be living healthy, going along their way, and then something happens, whether it's a big injury, an illness, lands them in the hospital. They suffer some sort of decline in almost all cases, whether that be physical or cognitive or a new physical dysfunction. And they get discharged home or to a skilled nursing facility, and you'll see that they don't quite get back to their baseline. But what worries me more are these people are at really high risk for things completely unrelated to their diagnosis. So something in their physiology changes. They're at higher risk for cardiovascular events, higher risk for inflammation, higher risk for infections, medication misuse. And so when we start thinking about the decline that follows, we're not just thinking about, okay, they were admitted for a heart attack. How can we prevent that from happening again? It's how can we really treat them as a whole? And so I think that's what we do here at Optispan is we get our patients in, we're doing blood-based biomarkers, we're doing genetics, we're looking at their physiology in real time with CGM and POCUS, we're getting a movement assessment, and then we can step back and look at the patient and say, where does your risk lie? And where are we going to get our biggest benefit? And where should we really intervene early? And so it's not looking at those really specific disease processes. I think it's more looking at the patient as a whole and how we can really increase their resilience.
I agree, obviously. And I think one of the ways I think about it is, in traditional healthcare, a lot of the times the conversations around, what's wrong or what's the disease or the symptoms. And I think one of the things, certainly that's part of what you do, but one of the more sort of overall approaches we try to take is asking more like, what could optimal look like, right? So just kind of a different conceptual framework. And maybe you can talk a little bit about how that changes the clinical approach that you take, kind of reframing it from, what's the disease or what's broken to what could optimal look like for this individual.
Yeah, I think it initially really changes the interaction. Patients come in and they're expecting me to say, okay, here's what's wrong and here's what we're going to do. And I think it's not looking like I'm the fixer. It's more stepping back and saying, what are you doing now? How can we keep you optimized? And I think that helps a patient feel seen, feel heard. And then we have a partnership. It's not where, the old school male doctors coming in and telling you what's wrong. It's more of a, what does your long-term future look for you, and how can we keep you doing all the things that you love, and what are the things that you love? And some of that will certainly be focusing on things like cardiovascular disease and metabolic dysfunction. But again, it's more looking at the person as a whole and what their goals are.
And also as an individual, right? A lot of the, standard approaches have been developed based on population averages, right? Even reference ranges and things like that. And the optimal may be different from the population, optimal for you or me as an individual. So how do you approach that? What does that actually mean in your clinical practice? And I'm sure there are lots of examples of people who you've worked with at Optispan where, the recommendations for them as an individual maybe didn't completely line up with what you would do if you were doing typical primary care, right? Are there examples that you can point to there? Yes.
So I think a good example is we had this one lady who came in and she was in her 60s and she had a cholesterol panel that was within the reference range, but not optimal. If you put her in the 10-year risk category for cardiovascular disease, it was low. She exercised regularly. She was very well in with a normal BMI, really low % body fat, low visceral adiposity. And we ended up doing a carotid ultrasound on her and found some plaque. And so if you were to put her in the traditional model, you would have said, okay, based on all of this stuff, we can let your cholesterol ride a little bit higher. Yeah. But because we found that she's starting to put down plaque in her carotids, makes us think she's putting down plaque in other places, we got more aggressive because she was really active and she did want to keep doing those things. She just had her first grandchild this year, and she wanted to be able to stay, get on the ground and play with her grandchild and doing all of those things.
That's a really powerful example. And I think, I think what you're talking about is the point of care ultrasound that we do sort of in clinic, right? It's a super non-invasive, really easy. Again, something that could be done in primary care, but isn't because doctors are trained, and there's a lot of reasons there. But that's a really great example of how you found something that wouldn't have been found based on just the standard blood work. And then it can lead you to, it's not necessarily diagnostic in that moment, right? But it can lead you to being more aggressive, doing further follow-ups and then putting that person on a different trajectory.
Yeah. And that's a great thing to remind me of. I am not a radiologist, so we definitely sent her for a formal carotid duplex to get the diagnosis. And then we changed our treatment plan once we had that information.
Yeah. And so the flip side of that's maybe worth talking about as well is, a lot of people have concerns about doing a lot of diagnostics on, healthy people, right? And the potential for overdiagnosis or even false positives, which is real. Like we should be aware of that and think about that. And maybe it doesn't make sense for everybody to have a whole body MRI or a Gallery test, both of which we do offer as part of our program. So how do you sort of think about that balance between catching things early, catching things that we wouldn't see that could create real problems down the road versus the challenges that go along with potentially false positives or over diagnosis?
Yeah, I think you just have to start with the patient in mind. So, someone like you don't mind you think knowledge is power. You don't mind getting additional tests. If I get an MRI on you and there's something abnormal that you need a needle biopsy of, you're going to be okay with that. If I have a patient in front of me who says, I'm terrified of needles or the thought of having an abnormal test is going to make me anxious, well, we're not going to do that. And so I think it really depends on the patient's, their desire to have that information weighed heavily with what is a positive going to look like for that patient? So we definitely don't do them on everyone. Before we do the Gallery test, I discuss with the patient what we're looking for, what the risk of getting a positive result, what's the true risk of having a cancer from that, what the test will tell us, what it looks for, because it tends to look for the faster growing cancers and not the slower, and really give them all that information up front and then let them make that decision.
Yeah. Yeah. And I mean, I think the Gallery in particular is a good sort of case example here where having that conversation up front is really important because I don't know if it's changed, but I think historically it's been if you get a positive, and basically Gallery just gives you a yes, no, right? Cancer detected, cancer not detected, right? If you get a positive, there's only like a 50% chance that will actually turn out to be a true positive. It's very rare, but it's still only 50-50 ballpark that they're going to find a cancer down the road. So having that conversation, making people know that, making sure people know that up front, and then each person can decide, is that information that I would want to have, right? But it's very individual. You're right. I'm like, yeah, just give it all to me and I'll deal with it, but I'd rather know. But some people, it creates a lot of anxiety. Yeah. So I do think we want to, obviously you and I will continue to be thoughtful about this. But I think as this field matures, we want to continue to be thoughtful about making sure that the information we're giving people is going to be valuable to them as we go forward. Have you had any examples you can think of where people got a false positive in our programs?
We have had 2 cases of patients getting whole body MRIs that had endometrial thickening. And I have since learned that they tend to overcall endometrial thickening. So there's different, like CAT scans tend to overcall a pericardial effusion. So this is something that I've learned from doing this and speaking to radiologists. Still, if you see it, we're going to send them for the transvaginal ultrasounds and see. The other thing I do want to note, because there was a New York Times article about this with the Gallery test, is even if you get these additional screenings and they're negative, that doesn't mean that you can forego the regular cancer screening, right?
Super important point. Yeah, great.
Because that's what the New York Times article is really pointing out with these patients who got these false negatives, got a false sense of confidence, and pushed off routine cancer screenings.
Right,
and then
mammogram, cervical cancer screenings, things like that.
Colonoscopy, yeah,
colonoscopy, right. And I don't think Gallery might detect colon cancer. I don't think whole body MRI typically does. So even these diagnostics aren't able to detect all types of cancer. So yeah, I'm glad you said that because that's really important that people don't think just because I go to Optispan, I don't need to do these. I don't need to get my colonoscopy, right? So by the way, this might be oversharing, but I may have told you I got put on the 2-year program for colonoscopies after my last colonoscopy. So,
okay.
Yeah, lots of fun.
So you'll get the gallery test and you will still follow up in a timely fashion. I did have the gallery,
and I will definitely stick with my colonoscopy schedule.
Well, congratulations.
Yeah, thanks. I felt pretty special. So one of the things that we talk a lot about and think a lot about is the value of repeated measurements, right? And so this idea of measure, intervene, measure again, the longitudinal measurements. And in many ways, I mean, I know in traditional healthcare, you're going to get annual, if you go to your annual physician, you're going to get the annual kind of baseline values anyways. But I feel like it's this concept of longitudinally measuring over time and really getting a very high quality baseline isn't emphasized in traditional medicine. And so I wonder, when you're working with clients, how does that change your perspective? The fact that we do have, quarterly updates on people's biomarkers, how does that change the way that you approach, your care for clients?
Yeah, I mean, the easiest way is I think that we can make more changes more often and get people, optimized sooner. But it also really helps me. So when I'm looking through and someone's getting a CRP every quarter and they're 0.3, 0.4, 0.5, and then they have one that's at 7, we're not going to jump to, there's something going, big change in their physiology. They're at higher risk for, having ongoing chronic inflammation. I'm going to say, okay, you probably had a virus, or we had someone who had a really aggressive laser treatment to her face and had a really high CRP, and then it came back down. So we're able to really pull apart signal and noise really well. I also think it's important, as you said, to really get the patient's baseline. So if someone always lives at a hemoglobin of 17, right on the upper edge of normal, and they come in and they're at 13, well, that's a really big drop, despite the fact that they're still technically within the normal range. Yeah. And so it lets us really see someone's trajectory quicker when we have more data points.
Yeah. And I think, again, thinking about this from my own personal lens, like I think you also sometimes see that there are biomarkers that are maybe outside the normal range, but for that person, it seems to be normal. Like I'm thinking of my creatine kinase in particular.
Yeah.
Right? I always run high. Don't know why. It's not like I've had it measured for 20 years, but for the last couple of years, my CK is always way higher than the normal range. And yet I don't have any symptomology suggesting that it's a problem. So is that just normal for me? And I guess we won't know for sure, but that's a trend. And if we see a change, now we know it's at least a change from where my baseline was. And I'm sure that's true for lots of biomarkers, that there are situations like that. So maybe it would be useful to talk about, what do the programs at Optispan look like? What do you do on a day-to-day basis? So we've got a handful of programs that we offer. Maybe you can take us through kind of what are the core features of those programs? Who are they right for in your mind? And what's the value that they bring?
Yeah, so our biggest program we call Helix. So all of our programs start with a gateway day. So with Helix, we do a blood draw, we do genetic testing, we put on a CGM, we get urine, we got people on the in-body. We spend, over an hour going through their histories, their medical problems, their medications, family history, their lifestyle pillars. So what they're doing, we literally have them walk us through a normal day of eating. So we have an idea of actually what's going in their body. What's the timing of all this?
Yeah. And let's just take a second there, because I think this is one way that this kind of a program is fundamentally different from what most people have experienced in healthcare, right? So you said we take an hour to go through that, right? You go to your typical primary care visit. It's, I don't know what it is now, 7 minutes. FaceTime you get with the doctor. And who's in that conversation usually in the gateway day?
So it's me, our health coach, and the patient. So I usually drive the discussion on what we call our foundations of health, going through, as I said, the medical history, the surgical history, medications, family history, really diving in who had what condition, at what year did they have it, different medications that they're on, and all of that. And then our health coach goes into really the nitty gritty of patients: eat, move, sleep, and connect.
Right, the pillars, yeah.
And so after that, we take a little break, and then we do point of care ultrasound. We do dermasensor, which is an AI-enhanced skin cancer detection method.
just for a second talk about what you look for on the point of care ultrasound? Because again, I think this is something where most people probably have never heard of this.
Oh yeah.
To me, it's like one of it's one of the most powerful screening tools that we have, and it's really easy. Like it's fast, non-invasive. And it's, again, from my personal experience as a patient, it's super cool to have an iPad there where you can actually see what's happening inside your body. So maybe take us through, how does that work and what are you actually looking at?
Yeah, so we definitely keep the iPad up so the patient can see it. When you go to your physician for an exam, they may, but probably won't, palpate your thyroid, which, they feel around, they have you swallow, they feel it go up and down. Unless you have some pretty big nodules, you're not going to feel much. And so we start with the thyroid. And so we put the ultrasound probe on the thyroid and we can see nodules, we can see masses, we can see if the tissue is not homogeneous, such as if someone has inflammation or thyroiditis. Then we look at the carotids. So there we're looking at the intimal media thickness, so the thickness of the walls. And we also go up to the carotid bulb because that's usually where we'll start seeing calcifications first if plaque has developed. After that, we do the liver and the kidneys. So with the liver, we're looking for one of the biggest thing is fatty infiltration of the liver.
Which is very common these days, unfortunately.
Very common. Yeah. Everyone always wants to see their gallbladder. Unfortunately, we have patients eat beforehand.
Wait a minute. Why does everyone want to see their gallbladder?
They always ask. And because we after people come in fasting, we give them breakfast as we're talking to them. So the gallbladder contracts. So we don't always see their gallbladder.
Right.
I have yet to see a diseased gallbladder.
So finish with the POCUS and then I'll come back to
So we're also looking in the liver for any abnormalities such as large cysts, large cysts, large masses. Then we'll go over to the kidneys. We'll look for normal size. Look for cysts. Simple cysts are pretty common. Look for any masses. Look for dilation of the collecting system, especially in older men who might have issues with their prostate. And then we do the abdominal aorta. So that is recommended in all men who ever had at least one cigarette in their life at the age of 65, just to make sure. We check it in everyone when they come through because it's just really easy.
Got it. Yeah. So, and again, I think, correct me if I'm wrong, I feel like many of the referrals that we have from the gateway day for further exams come out of the point of care ultrasound. You see an abnormality, and then it's kind of a discussion about, is it common enough that you don't think it needs a referral, or you send for a referral for a more, detailed scan of some type? Could be ultrasound, could be MRI at that point. Does that fit with your experience? Yes.
Point of care ultrasound is all the training that you really find for it is going to be for acute medicine. So that's where my training came from. It is looking for how you can use ultrasound in the hospital. And so you're looking for very different things. So while I'm getting, very comfortable with using the ultrasound, it's not necessarily for checking for, things on the thyroid or the carotid. So if I find something, almost always I can think of one time where I didn't send someone where I was confident enough that it was benign. Otherwise, I want to have an expert look at it. And the referral is for an ultrasound. So it's also for something completely non-invasive.
Right. Okay. So we kind of glossed over it, but you mentioned that the people come in fasting, right? So they come in fasting. First thing is a blood draw, right? So it's a pretty comprehensive blood test. Maybe worth just at a high level talking about what are the sort of categories of biomarkers that you're looking at in that comprehensive blood test. And again, how does that differ from what people are typically going to get from a primary care visit?
Yeah, so the first one that comes to mind easiest is cardiovascular. And so we do advanced lipids. So we're not just looking at LDL, we're looking at LDL particle number. So we're getting a lot more information. We also do an apolipoprotein B. We do an LP(a). We do the cardiac CRP, as well as the homocysteine level. So I think those are kind of the bigger things that we do different than a primary care physician.
And don't worry if you leave a couple out. I'm not asking you to go through the entire panel. At some point, we'll put the entire panel out there for people and hopefully be able to even create a way for people to get access to those tests directly. So don't worry about if you leave a couple things out.
Perfect,
but sort of high level. And I guess really what I'm trying to emphasize is, what are we looking for big picture in terms of like systems of health? And again, at a higher level, how does it differ from what most people are going to get from their traditional medical experience?
So we're looking for cardiovascular. We're looking at metabolic, kidney, liver, an extensive hormone panel. For our Helix patients, we're also doing an autoimmune panel.
So inflammation and autoimmunity kind of all wrapped together. Yeah.
We do PSA in all men annually. And then a bunch of different nutritional ones. So we're looking at vitamins
and metals and toxins, right? Yeah. And then on the metabolic side, because that's the other one where I think, obviously metabolic dysfunction is a huge problem in the United States and most countries, especially in an aging population. Maybe drill a little bit deeper on what are some of the biomarkers there that are most informative and go beyond what people are typically going to get.
Yeah, most people get a fasting glucose because they get a basic metabolic panel and they get a hemoglobin A1C that looks like the average blood sugar over the past 2 to 3 months. We look at a fasting insulin, which I think is probably the number one test that everyone should ask their primary care physician to get.
Isn't it bizarre that that's not part
it's
of the standard?
So informative.
Yeah, I agree.
So,
completely.
we've had patients who have a hemoglobin A1C of 5.2, but they have an insulin of 90. I mean, they're insulin resistant, but they're managing to compensate. And maybe, but that's not going to last.
I was going to say, maybe explain why is that a problem? Because people might be like, well, it's working fine, right? Why is it a problem to have insulin resistance, even if your A1C is normal?
Well, I think most people think of insulin as doing one simple thing, moving glucose from the bloodstream into cells. But it does a lot more than that. It's involved in inflammatory pathways. It's involved in lipid trafficking. It's involved in vasodilation. And so it does so much more to your body. So having those astronomical levels, even if you have a normal blood sugar, is still doing a lot of underlying damage.
And what you said is it's not going to last, right? I think that's the other thing. Eventually your beta cells are going to wear out. The system's going to stop working. So it's a symptom of that you're on the path to diabetes for almost everybody, right? So anything else on blood work that we didn't talk about? I guess one of the things I wonder about, I mean, I think absolutely we want to measure, the heavy metals and other toxins that may accumulate. How often do you see a signal there? In other words, is it something that is common or uncommon that you see a signal where you actually make a recommendation to the person, oh, you should figure out why your mercury's high, or stop eating so much tuna, right? Does that happen?
So the mercury one, yes. We have a lot of people who love sushi and other things, or they think they're doing the right thing by eating fish every night and replacing, any other sources of protein, but they're not focusing on the size of the fish and everything else. So 100% with the mercury. We recently had a couple come in with lead levels that were not undetectable, both of them. And so they have an old home in another city that they're going to get their water checked. So, I mean, it wasn't to an astronomical level, but, you imagine grandchildren coming to the house or something else, they're probably going to be okay, but a young child might not at the levels that they were at.
Right. So good information to have. It's kind of the thing where probably going to be fine, but if there's a problem, you really want to know.
Yeah.
Okay, that's great. So we talked about, so they come in, they get their blood work, point of care ultrasound, have something to eat, so everybody's, not hangry anymore. Then what happens on the gateway day?
We also do a 3D intraoral scan, which I think is really important. There's the more data that's coming out that shows inflammation in the mouth is really highly correlated to heart disease and dementia. And so if anything, I think it really gives the patient the impact of, okay, I have to start really focusing on my oral care.
Yeah. And I mean, I'm glad you said that. So two things there that I think are worth maybe double clicking on or emphasizing. One is just the importance of oral care and the fact that that's something that for cultural reasons, we separate the mouth from the rest of the body. It doesn't make a lot of sense, but typically the mouth doesn't get paid attention to in a healthcare setting. Even in a lot of the high-end concierge programs, very few actually look at oral health. So this is a way in the context of what we can do in the clinic where we can get these high-resolution images of the mouth. We have a dentist who consults with us who can then, refer people for oral care if needed. And a lot of what we do is around behavior modification, right? And education. And so, like you said, it emphasizes for people, this is important. You should pay attention to oral health because if you have poor oral health or periodontal disease, you're at higher risk for a bunch of other bad stuff that is not consistent with health optimization. So that I think that's important to note, and hopefully more of the longevity medicine providers will start to think about oral health.
And then after that, the other thing we do is the AI enhanced skin cancer screening. So if there's any abnormal moles, either that the patient's worried about or I see, we put this little device on it and gives us a risk of there being malignancy, which really tells us how quickly do we need to get someone in to see their dermatologist. And then after that, they go in the gym. So they have about, I don't know, maybe an hour, hour and a half where they get a full movement and mobility assessment. So they focus on balance, mobility, strength, and then cardiovascular fitness with a VO2 max.
So you just talked about the movement assessment, right? So, okay. So as part of that movement assessment in the gym, we're going to get flexibility, mobility, strength,
balance, which is super important.
Balance, super important, and VO2 max. And then what happens after they're done with the movement assessment?
If they want to shower, they can. Then they come back in. We have lunch set up, and we go over their results of the movement assessment. We go over their results of a DEXA scan. So I didn't mention that. We have a patient get a DEXA scan ahead of time so we can look at how much visceral fat they have, we can look at their bone density, and we can look at their appendicular lean muscle index, which is the amount of muscle you have in your arms and your legs compared to your height. So after that, we talk about next steps, which involves undergoing some, they're not really brain games, but we use a platform that helps us understand how a patient's mind is working in 12 different avenues.
Right, different cognitive domains, right?
Exactly. Yeah. And so we have them take that test, and then when they come back, we put everything together, including this brain aspect.
Right. So, okay, so that's the gateway day. And then for people who want it and or it's appropriate for whole body MRI is on the menu. Any other exams that are or diagnostics that are particularly common? I guess coronary scans for a large number of people as well. And then we talked about Gallery. That's part of the blood work. Some things that are not included, and people may be wondering why, although we've talked about on the podcast, microbiome tests at this point and biological age tests. Do you want to comment on why we don't include those as part of our program, or at least as part of the standard programs?
Yeah, I mean, we haven't really found them to be reproducible. And so if someone's going to take two tests on the same day and give us two different results, I don't really know how to interpret that for them.
So it's not useful from a clinical perspective right now. The other thing we didn't talk about is genetics. So do you want to just briefly talk about how genetics can help inform the picture for a patient?
Yeah. So when we look at genetics, we look at a couple of things. One is, specific disease processes. So we'll look at your genes to see where you are with ApoE status. We'll look at for things like hemochromatosis and other more rare but really impactful disease processes. And then we also look at polygenic risk scores, which is taking, thousands of different gene variations and giving us a risk that you might be at higher risk for a heart attack or diabetes. And while we don't make recommendations based on those polygenic risk scores alone, it just goes into creating a whole picture for the patient. So when we look at the metabolic system, we're looking at fasting glucose, we're looking at fasting insulin, hemoglobin A1C, HOMA-IR score, LP-IR score, uric acid, and if they have a polygenic risk score that's really highly correlated with diabetes, they have a family history of diabetes, we're probably going to be more aggressive with that patient earlier.
Yeah, absolutely. And then most people go home with a continuous glucose monitor, right?
Yes.
You want to talk about that and how that fits into the picture?
I think that is also one of the most impactful things that we do. And I think almost anyone should get one. It's really interesting to see how your body responds to certain foods. So even if you are, metabolically healthy on all other aspects, you can see which different foods does your body not react to well. How should you eat your foods? Do you respond well to a fasting window or not? Another thing that's really big is how does your body respond to alcohol? So people will be surprised, like, what happened at 3 a.m.? My blood sugar spiked, and it's the alcohol is going to drop it, and then it's going to go up. And so you see these really big variations based on really how you live your life. I noticed for me, blood stress is a really big, it jumps my blood sugar up. And some people don't notice that. Yeah. So it's just really learning your body. So even from taking a step back from me and the doctor, the patient really understands their body and how it reacts to different things. And as we've spoken about, you can't ignore those large spikes. Like once you've seen it,
I think,
you know they exist.
For me, I mean, I agree. That's been my experience too. I learned so much the first time I did CGM, and then every time I've done it since then, which is usually once every 6 months or so, I guess, I learn new things. But what really, I think, affected me is how sticky it is in the sense you can't unlearn what you see. And so you will it's, in my view, a very useful behavior modifying tool for that reason, because I'm going to think twice every time I want to have a bagel.
That's what I was thinking, your Cheeto bagels.
So the other thing that I can think of that we haven't talked about that everybody in the Helix program walks away with is an Oura ring for sleep tracking. And this is not a plug for Oura. We don't get any money from Oura. Whether Oura is the best tool for sleep tracking or not is a different conversation. That's what we have used historically, and it's what we still use. But maybe talk about, why do we do that? What sort of information do we get from the Oura ring that, again, helps paint the entire picture for the person?
Yeah, I think, first of all, most people overestimate the amount of sleep that they're getting. So they think I got into bed at 10 p.m., I woke up at 5 a.m., so I got 7 hours of sleep. They're not realizing how much time it took them to fall asleep, how many times that they're getting up. And so I think it really does help a patient understand what's happening in their body when they're going to bed. It's also really important because I think people have this mindset of we'll sleep when we're dead. And more we're knowing how important sleep really is for your long-term health. And so we can really help optimize it. So patients can learn, okay, when I'm sitting in bed working and I put my computer away, according to my Oura ring, it takes me 50 minutes to fall asleep versus if I'm reading a magazine. And so you can make lifestyle adjustments based on that. Sure. We also look at the amount of deep sleep someone's having and REM sleep. And so deep sleep tends to happen earlier in the night. And so if someone's drinking a lot of fluids during the day and they're waking up 4 or 5 times in the first 3 hours, they're getting essentially no deep sleep. And that's really when your lymphatics are clearing away all the debris. And so we get a lot of information about how much someone is sleeping, what the quality of their sleep is, how interrupted it is, diagnosing obstructive sleep apnea. You can look at a look at a Oura ring. We're not making the diagnosis based on the Oura ring, but we can say, okay, you're waking up a lot. Let's send you to get a formal sleep study. So I love using the Oura ring with our patients. It gives us a ton of information.
Yeah. And I think, a lot of people get hung up on, well, how accurate is it? Is it accurate enough? And that's important. But I think, the goal here is really to identify patterns. And so if there's a little bit of noise in the measurement, that can be tolerated as long as you can pick out those sorts of patterns that you were just alluding to, right?
Yeah. And I think it's important to tell people this is not a medical grade piece of equipment, right? This is a commercial direct to consumer. We're using it in our clinic because it's one of the best things that we have at our disposal.
Well, and I would say unlike the biological age tests or the consumer facing microbiome tests, it's accurate enough to detect patterns, right? So again, there's a balance between separating signal from noise, and it's at least been our experience that the Oura ring is pretty good for detecting signals, right? The other thing I learned from Oura ring, which is something everybody who I know who drinks alcohol and uses Oura ring consistently reports, is how bad alcohol is if you drink it at night before you go to bed for your sleep quality. Okay, so maybe it would be helpful then. So we talked about all the stuff that we measure, at least the stuff we can remember. Maybe we can talk about at least some of the things that get picked up by all of those diagnostics that typically might not get picked up in a traditional healthcare setting. So you mentioned fatty liver. That's probably a really good example. Lots of people with fatty liver don't get diagnosed until it becomes a problem. What other sorts of things can you find through this sort of gateway approach that, even if it's just from a screening perspective, not diagnostic, can lead you to get a diagnosis?
I mean, the biggest one is insulin resistance. And I'll keep coming back to insulin resistance because, to me, it seems like it's the root of all evil. And so when you see someone where everything else is optimal, but they have a high fasting insulin, and then you look at their body composition and they have an elevated visceral fat, they're on a bad path. And so I think that's one of the biggest things that we see is people come to us and they said, my doctor said my hemoglobin A1C was 5.6, so I'm okay. But there's a lot more to that story than just that.
Well, and in the case of insulin resistance too, you sort of alluded to it, there are multiple reasons that somebody can be insulin resistant. So if you don't have the DEXA and the fasting insulin measurement, you might not know why is that person insulin resistant. It struck me, I'd never really thought about this before we started Optispan, that, there's a subset of people out there. There's a lot of people who are insulin resistant and have diabetes because they're obese and eating a poor quality diet. And it's been sort of that, canonical progression to diabetes. But there's a subset of people out there who look really fit, right? You look at them, you're like, wow, that person's in really good shape, but they're under muscled. And so that lack of muscle is leading to the insulin resistance, or at least poor glucose handling. And so without the suite of diagnostics, you wouldn't necessarily know what to pick up on, right?
Well, and with all the diagnostics and the movement assessment and everything else, we can really pick which lever we're going to pull first. Right. So, someone having insulin resistance, I'm not jumping on medications right away in a lot of cases, but we can look and say, your sleep quality is terrible. Like, that's going to affect your glucose
or your
metabolism.
hormones are dysregulated.
Yeah. So I think it also helps having all that information and having their pillars information to figure out where are we going to intervene first. Because we always talk about stacking small habits. And that's why we have a health coach who works with the patients in between our appointments, because we're not going to walk away from our appointment and say, okay, cut out all refined carbohydrates, exercise 40 minutes of cardio this many times a day, do this resistance training, sleep this much. That doesn't work. Yeah. But they work with our health coach and they come up with their goals and they make these small steps. And over time, stacking those small steps makes a really big difference.
Right. Yeah. So any other sort of categories of things you want to touch on that we're able to catch early? I mean, we talked about cancer. That's sort of obvious. We do a lot of cancer detection. Early heart disease, you already talked about. Some of the cysts or growths that you can see out of point of care ultrasound. Anything else that rises to the top of, sort of maybe not common, but not uncommon conditions that people have, may or may not rise to the threshold of disease diagnosis, but if caught early can be acted on and fixed.
Yeah. Well, the next one that comes to my mind is one of your favorites, hormones. So I think it's very common for people to relate a lot of feelings as we age and metabolic changes with a woman after she goes through menopause. But people don't really think of men in this. And so we had one patient in particular who felt fine, was exercising all the time, couldn't put on muscle. But the other big complaint was he wasn't sleeping well. And we got him on just a little bit of testosterone. And he called 4 weeks later and just couldn't believe how well he was sleeping. And so some of those hormone changes really make an outsized difference. We had him on topical testosterone. So he wasn't even getting a ton.
Yeah.
And it just really put him, it was just an edge, and he just felt like a different person within a month.
Right. Yeah. And again, we've talked about this before, but worth mentioning explicitly, in men, just measuring total testosterone isn't going to give you the picture. You really have to do that whole panel of hormones, and optimally, you're going to have all of the other information that we've talked about as well. I would say maybe not a majority, but a significant fraction of our clients are, high performing people, health conscious. They feel like they've sort of got things dialed in, but they want to get everything they can. They want to optimize, right? Are there any blind spots you commonly see in those kinds of individuals who come into a program like this?
Yeah, the first thing that comes to mind is how important sleep is. So a lot of people are, they have their full-time CEO job. They're sitting on 4 boards. They're constantly traveling to give talks or go attend things, and their sleep is really struggling. I'm going to say it again, but insulin resistance, a lot of people don't know that they have it. And the other one in this particular population that we see is how important alcohol use is, or alcohol misuse is, I would say, because it is very common when you're going to all of these events that you're having drinks at them. And so people are drinking a lot more than they think is a problem. You know what I mean? They think, oh, well, I just went to here and I had 4 drinks because it was this event. And then I didn't drink the next day, but then I went out to this event.
And a lot of times it's a social thing, especially if it's like a business meeting, you feel like that's just what's expected. So yeah, I can see that for sure. One thing that I picked up on, partly because for me personally, this was something that I learned, but I think I've seen this in some of our clients as well. I feel like that particular group, when we think about the pillars of Healthspan, they may, have diet and exercise dialed in. You mentioned sleep, but the connect pillar, I think, is one that sometimes in that group, it has been under prioritized, right? The importance of relationships or personal sort of stress management techniques. Does that kind of fit with your experience?
Yeah, it can be. with our patient population, there's one person that comes to mind who travels frequently for work and has a few homes. But then when you speak to them, they just express this loneliness. So while they're constantly surrounded by people, because of the busy lifestyle, because of living in all these different places, they don't have that core support.
Like real meaningful relationships.
Exactly.
Yeah. Okay, so we talked about the sort of, I don't know what the right way to say it, executive, high performer, some biohackers. We haven't talked yet about the PRO program. This is a corporate healthcare program that we run where it's a little bit of a different, I think, demographic population. I would say, you correct me if I'm wrong, it's probably a pretty accurate representation of middle-class Pacific Northwest patients. In that population, I guess the question would be, how do they differ? What are some of the potential biggest levers to work on there or biggest blind spots that people may have when they come into a program like what Optispan offers compared to what they're going to see at their typical primary care visit?
So it's going to be a lot of the same things that we've been talking about. We're finding a lot of insulin-resistant metabolic dysfunction. We're seeing quite a bit of obesity. And a lot of it, too, is around the eat pillar in particular, where they have really busy lives at home. They have really busy lives at work, and it's hard to really carve out that time for meal planning. And so it's common for patients to be going out to eat every day for lunch. And it's got to be somewhere fast because you only have a 30-minute break. And so it's really trying with this patient population to work some of these healthy habits into their lifestyle. So their lifestyle pillars we focus on a lot.
Yeah, that makes sense. And I think, in every category, I imagine you're dealing oftentimes with people who feel like, the problems are years away. I don't have diabetes yet. I don't have, diagnosed heart disease. How do you navigate that and instilling, a sense of urgency in people about the time to act is now?
So I think a lot of it is actually describing how the physiology of this happens. So yeah, someone might have high cholesterol, but their coronary scan is 0. And so it's like, well, I don't need to worry about it. Well, when you explain how these, ApoB particles get stuck in the endothelial wall and you can explain how the cascade happens, it's like, yeah, you don't have this now, but it's a setup. And I think when people understand the physiology behind it, they become a little bit more, they feel more urgency in fixing it versus waiting for a problem to happen.
Yeah, absolutely. The other thing that I've seen a couple of times is because you get data from a variety of different sources, different types of diagnostics, when you start to get multiple things pointing towards the same potential problem coming down the road, it helps. Like, genetics, I think, is a tool. You said we don't use it in diagnostics, but it can help tip the balance if you can say to somebody, yeah, you've got high cholesterol, and you've got a genetic predisposition towards cardiovascular disease, we should really deal with this now. I think being able to point in multiple things at one time can, sort of be a reinforcing process. And then they put the CGM on and they're like, oh my God, I can't eat that bed now, right? Okay. I know this happens from time to time where people come in and they know what they want. How do you say no to a client if they come in and they say, I want you to prescribe me X, and you feel like that's not the appropriate thing for them? How do you deal with that?
Well, I think the first thing that we do is we establish trust. So with our gateway days, I love our gateway days because they're really big, they're really long, they're really comprehensive. And so the patient starts to view us as part of their team. Like, oh, these people are really taking an interest in my health because they're spending 5 hours with me. And so you really build trust with the patients first. So before a patient even has the opportunity to say, I want this, we've already spent all of this time with them, really gaining their trust and having an alliance. And then whatever they want, I don't slam the door in their face and say no. Let's understand why they want it. What do they hope to get out of it? What are the risks involved in it? And is there a bigger lever that we can pull? And I think focusing on those things. The other thing is that I believe in patient autonomy. So if someone really wants to try something and I can't really see a negative behind it, I have no problem trying it and seeing what's going to happen. So, looking at those new monoclonal antibodies for dementia that has a high risk for brain bleed, if someone came in and said, my mom has dementia, I want to start this now, well, looking at that risk benefit, that doesn't make sense. But if someone comes in and says, my husband just started X medicine, I'd like to try it. And I'm looking and I'm like, okay, well, you're not at risk for this, this, and this. Let's do it. And let's see what happens. And what's nice about our programs is we don't see them once a year, right? They keep coming back. We're in constant communication with them that will know if a problem comes up. So while I don't have appointments with patients more than quarterly, I'm always available, but they're reaching out to our health coaches, and our health coaches are talking to them along the way. And if something comes up, they let me know and I reach out. And so I think it's a safe environment to try things that may not be recommended by me, but if a patient really wants to do it and they have a good reason, I'm not necessarily opposed, if that makes sense.
I love that. And I think this is a really clear example of where, a Healthspan Medicine program that functions well really differs from traditional healthcare, and also from, what I would say some of the longevity medicine programs that I would suggest aren't functioning well, in the sense that the perspective should be around, first of all, what is the overall information we have about this person, where they're at, what their goals are, where we want their trajectory to go, an understanding of the true risk reward as best we can evaluate it right now, and an openness to have a dialogue with the person. And like you said, in the context of having established trust, and to allow the patient to make an informed, have an informed opinion on their own health. Like, to me, that's where we should strive to get to. It's challenging in this space. And so I want to talk a little bit in a minute about some of the medications, supplements that you feel strongly about that we use in our programs. But first, also to ask how you deal with, because I know you get these questions all the time, a lot of the therapies, approaches that are out there in the longevity space right now that may not be as evidence-based, or maybe there's some evidence for it, but it's in this regulatory weird zone, or people have to go to the secret island to get the therapies. Like, how do you navigate the things that are less evidence-based, less data-driven? And I mean, we can talk about specifics, but, I'm thinking things like NAD drips, or, peptides are a big category, but there are some peptides that are FDA approved, a lot that aren't. Stem cells, exosomes, gene therapies. Like, how do you navigate that with patients?
It's really hard.
Yeah.
I think the first thing that I do personally is look to see, is there any evidence? So when you're looking at stuff like tesamorelin as one of the growth hormone releasing hormone analogs, like that actually is FDA approved. So I know specifically what are the risks, what are the benefits. Now, we don't know in our patient population because it's FDA approved for HIV lipodystrophy, but at least I know, at least I can have an honest discussion with the patient about the risks. And then you can kind of extrapolate from there. There are some other growth hormone releasing hormones out there that I can say, okay, well, I know from this drug that works very similarly what the risks are going to be. And so it kind of can help guide that. I also think it's important to look at where the studies are coming from. So there's a couple peptides that are all the research is out of one specific institution in Russia, and it seems to be commonly used in Russia. So you can extrapolate that maybe it's safe. But again, until we have more studies from different places saying that it's safe, I'm not going to say it's a slam dunk.
And with the peptides in particular, it's also challenging because the sourcing is not always clear,
yes,
right?
Yes. And so, there are a patient just sent me a website where you can go on and fill out an online questionnaire, and they will send you whatever it is that you're requesting. And so if that was a place that I would be sourcing my peptides from, I would be very worried. If they're willing to really bend the rules that much, they're probably not going to have the purest product.
We haven't spent a lot of time on the pillars of Healthspan. I don't think we necessarily need to in this conversation. Maybe we'll save that for another conversation about, some of the things you've learned and how you approach that with people. Because obviously that's the foundation. I think we both agree on that. But once you get past the pillars, a lot of people want to know about, medications and supplements in particular. And there are a couple of things that I think people often think about with medications and supplements. One is as a preventative for common diseases, diabetes, heart disease, things like that. The other is longevity. Both of those are important. Maybe we can talk a little bit about, if you have anything you want to share about your sort of overall philosophy to the use of supplements and medications in a preventative perspective, and then some of the specific ones that rise to the top in terms of our patient population that you have a lot of experience with that you think are useful. And we can talk about the specific use cases for each one.
Yeah, I think in terms of supplements, it's going to be magnesium, vitamin B12, and vitamin D are the ones that we really go to often. I think that there is some good reasons to believe that having a vitamin D within a specific range is going to help your bones, it's going to help your mood, it's going to help your immune system. With the B vitamins a lot, we're looking at homocysteine in particular. So we want to make sure that someone has good, but also some people just feel like they have more energy if they're taking their B vitamins. Great. With magnesium helps a lot of people relax at night and helps to get them in the right mode for sleep. And so I think that's really helpful. It's also good for bowels. It's also good for bones. So we get a lot of different benefits from those three supplements. So those are the ones we recommend a lot.
And the B vitamins, just for a second, there's a relatively common genetic variance that can influence in that. So you said you'd be guided by homocysteine, but the genetics can also, I think, be informative in some cases with the B vitamins as well.
Yeah. So when we do our genetics, we're looking at that MTHFR mutation. Right. And then if someone has that, we're usually putting them straight on methylated B vitamins so that they're going to get the most bang for their buck there. A lot of people have a hard time getting all of their omega-3s through diet. Fish, especially well-sourced fish, can be really expensive. So we do recommend fish oil a lot. We do a fatty acid balance test on our patients and see where people are. Most people do need some sort of fish oil, or I'm a big fan of flaxseed and hemp hearts and all the things you can kind of sprinkle in food. Like if my kids have a peanut butter and jelly, there's hemp hearts sprinkled inside of it.
And you get fiber at the same time, right?
Exactly. Yeah. And you can put it in so many things without tasting, seeing.
Mm-hmm. Yeah. Okay. So the only two you didn't mention that I'm currently taking are lithium. Do you have any thoughts on lithium?
Yeah. So I was, when was it? Maybe a year ago, you had someone on the podcast who was talking about low dose lithium.
John Byrne. Yeah.
And I thought that was kind of a crazy idea just because I spent so much time working in a hospital and I saw people coming in with acute kidney injury, diabetes insipidus, thyroid problems because they're on lithium.
But these are psychiatric patients?
Yes. But then that Nature paper came out talking about all the benefits. And then when I started looking at how much lithium orotate we're talking about versus the lithium carbonate that people are on, I think at low doses, it's really, really safe. That's definitely one where you're talking long term. You're not going to feel any benefit from taking it.
Right. And the levels there, just so people are clear, are ballpark what you get in some places in the world in drinking water. So again, likely not any long-term negative consequences that are significant. And if you're in a program like ours, you're going to be monitoring biomarkers quarterly. And so you would see it early on would be the expectation.
And it's nice with lithium because they're big ones that you have to worry about are kidney and thyroid, which are just so easy to test.
Right. And then creatine.
Oh, yes. I love creatine. I'm on it too.
All right. 5 grams a day is what I take.
Mine's slightly under just because I don't take the time to level out my scoop. Okay. But yeah, no, there's really good data in muscle growth and also emerging for brain health. So especially for women going through menopause, it's really hard to put on muscle. Your brain function can start to decline. And so I think creatine's a great one.
Again, not a lot of downside. This is always the kind of risk reward sort of thought process. And then there are lots of other supplements that on a case by case basis, but that's pretty much the short list for what you think is common in our patient population. What about medications that are commonly used in a preventative way? Obviously, there's a lot of we do a fair amount of reactive stuff, right? If somebody's got early heart disease, high lipids, you might put them on a statin in a reactive way. You might also use a statin preventatively. So let's talk about the stuff that's mostly or can be used preventatively in an effective way, managing risk reward.
Yeah, I think the first thought that I have is a GLP-1.
Interesting.
So we have a lot of patients where their blood-based biomarkers may all look pristine, but they have 3 pounds of visceral fat.
Yeah.
And their body fat percentage is, 18.
And just to clarify, you learn they have 3 pounds of visceral fat from the DEXA,
yes,
right?
We wouldn't know otherwise. Right. And this individual is working hard, they're eating well, their body fat percentage isn't very high. We might not be able to get them down near an ideal body fat percent or visceral fat content. And so we know that if we're able to get that down, we're going to decrease the risk of metabolic dysfunction, decrease the risk of inflammation, decrease the risk of certain cancers. So we use GLP-1s pretty often and not just for diabetes or obesity.
That's a great example. And again, I think, GLP-1s are interesting because, first of all, they're very effective, right? They work for most people. And they seem to be polarizing in society right now. And there seems to be at least a fraction of society that's, going to criticize anybody who's on a GLP-1 who isn't, obese. And I think you made a perfect case example for where it could be useful to keep people from developing diabetes or other inflammatory associated conditions. And you've got a really nice biomarker to use to guide. Now, when used in that context, is it your experience that it's usually like the FDA approved dose, or is it what people call, micro dosing, which is really like a half or a quarter dose? We
normally put people on the lowest FDA approved dose. So for tirzepatide, 2.5. And most people don't need to go up. They get a little bit of effect, but I don't want them having nausea. I don't want them not wanting to eat, right? Because in this case, this person doesn't have obesity. So I want them to be able to get the amount of protein that they need in a day and their micronutrients. And so we want the minimum effective dose for these patients.
And is it your feeling that tirzepatide is probably the go-to at this point, or are there some other things that determine, which of the GLP-1 variants that are out there is going to be most effective for that person?
I usually go to tirzepatide first. It tends to have more effect at the smaller doses. But, I just had a patient who their insurance company declined that, but they approved semaglutide, and this person wanted to get it from a pharmacy and not a compounding pharmacy. I don't see a downside to using semaglutide.
Sure. Okay, great. Okay, so GLP-1s. What else is on the list?
SGLT2 inhibitors. Yeah. So, that's a medication for diabetes. It's also for patients with CKD. But if I have someone who has, maybe a little bit of insulin resistance and their blood pressure is slightly above where we want it to be, the SGLT2 inhibitor can give us improvement in both. Yeah. And so I would use that in a lot of cases before disease has developed and kind of hits a bunch of different avenues. I haven't started using it. I only have one patient on it who has really no indication for it, if that makes sense. There's one patient on it for longevity purposes, but everyone else, there is usually a reason. There's a little bit of kidney dysfunction or a little hypertension or a little insulin resistance, or maybe it'll give them a little boost with weight loss, something like that.
Yeah. So in my case, as you know, and as I've talked about, I'm on Jardiance, which is empagliflozin, so one of the SGLT2 inhibitors. And so you mentioned for longevity purposes, the rationale there is that it's been shown to increase lifespan in mice. Whether it slows aging in people or not, unknown, but maybe there's some interesting human data there. But in my case, I was trending towards pre-diabetes. I hadn't yet hit that threshold, but I'd done pretty much everything I could reasonably do around diet and exercise and sleep to the extent I could. That to me, that just seemed like a rational way to bring my glucose down, hopefully see an improvement in insulin sensitivity. And the risks seem very manageable. Like you would know more about this than I do, but my understanding was and you might get a benefit for like kidney function and other things where the SGLT2 inhibitors seem to be showing benefit. The only risks that I picked up on that seemed, possible would be an increase in urinary tract infections. And now that I've done a little bit more digging, that doesn't really seem to be an issue in healthy people. Is that sort of your experience that the side effects seem to be pretty minimal in the patients that you've got who are taking these?
Yeah, some things you have to watch out for when you're talking about a healthy population is going to be decreases in blood pressure. So it's working,
too well for
yes,
blood
it's
pressure.
working, a little bit like a diuretic. And so if you have someone who's got low blood pressure to begin with, you're going to have to watch that closely. And it could also cause hypoglycemia. So if someone also has low blood sugars, they're on a very low carb diet, it's going to cause you to pee out a bunch of sugar. Yeah. And so you want to make sure we're not going to place someone at risk there too.
Yeah. So we've talked about GLP-1s, SGLT2 inhibitors. Anything else come to the top of the list?
It's PCSK9 inhibitors.
Yeah.
So a lot of people go on them once they get an elevated coronary scan or CCTA, or they have really high cholesterol.
And this would be Rapamycin, right?
Rapamycin,
that's the name
yes.
most people are going to know it by, yeah.
Which I actually really love it for those indications, because a lot of people have a hard time on a statin getting their numbers to be optimal, whereas a lot of those patients just go on Rapamycin and they don't have to add on second or third agents. So I really like it.
And again, I think I talked about this on the podcast, but I started Rapamycin. It's probably been 2 months now. And in my case, my lipids were suboptimal, very early heart disease based on the CCTA with contrast. And so I thought it just made sense to, like you said, skip the statin and see if I could knock the lipids down to where we want it to be. And I've always had ApoB and Lp(a) not outside of normal, but higher than I want it to be. So I haven't gotten a blood test since I started Rapamycin, but I'll be interested to see, where I land. So in my case, it's not a true preventative.
I mean, that's treatment dose. You've
disease.
Got coronary disease. Yeah. Coronary disease is coronary disease.
Right. So, but I'm trying to keep it from becoming something significant, right?
I do have one patient that we just started Rapamycin on who had the coronary CTA and doesn't have any disease. Thought process there is he's in his young 40s and his LDLP is astronomical. And so you think about the process where you're getting atherosclerosis, right? The ApoB particles are getting stuck in the endothelial wall, and over time that's causing damage. So when we're looking at it on the coronary scan, we're looking at big vessels. What we can't look at are those really small vessels in the brain. And so it just makes sense to me that he doesn't have this disease process now in his heart, but we do need to we need to protect those small vessels. And given how high those numbers are, we did just start a PCSK9 inhibitor. So I'm redrawing his blood this week and we'll see where we are.
Yeah. Maybe worth also mentioning, I think there's a lot of, confusion and concern in some people's minds around insurance and Rapamycin. So it's pretty expensive. And I've been told that many insurance companies won't cover Rapamycin until somebody tries a statin and the statin is not sufficient. So I think it's very independent, depends on your insurance company, but worth just putting out there. I think the manufacturer of Rapamycin has a program where if your insurance won't cover it, you can get a discount on the medication. It's unfortunate that, for some people it might benefit. The insurance piece is the limiting factor, but just put that information out there that sounds like there are ways to get the cost reduced if your insurance won't cover it.
Yeah. And in good news, because Rapamycin did that, insurance companies are now starting to cover it. So the last few times I've written the prescription, it hasn't even needed a prior auth, because if we go around them entirely, they make absolutely no money on that decision. Right. So they are starting to cover it more, which is great.
That's great. Gotta, create the incentive structures to get insurance companies to do what they should have done in the first place. Wouldn't that be nice?
Won't touch that.
Yeah. Okay. So the one we haven't touched on is Rapamycin. Do you want to, I know a lot of people come into our programs already on Rapamycin, potentially wanting to get on Rapamycin. What are your thoughts there? How do you approach that? What's been your experience so far?
Well, I share an office wall with you, so I can't really say we don't do Rapamycin. My experience with Rapamycin has been really great. So initially when I started talking to you all at Optispan, I was a little bit reserved on that one because it's just my experience in using it was all in transplant patients in the hospital. But doing my research and seeing it in action in patients, there's very little downside at the small doses once a week. There's good evidence in so many different animal models. You continually bring me different papers showing people with ApoE3/4 and what it's doing to the brain. You recently showed me one on skin cream and how it really reverses signs of aging in the skin. So we actually created a rapamycin cream with a local compounding pharmacy that has GHK copper in it and it has hormones in it. I'm using it every night.
I've heard you look great, by the way.
Thank
you. I've heard several actually very positive reviews of the skin cream from some of our clients. So
yeah,
I have to remember, you guys can tell I haven't been using my Rapamycin skin cream, but I have to remember to try it. The problem is my refrigerator is downstairs and my bathroom, where I brush my teeth before going to bed is upstairs, and then I don't want to go back downstairs to get my Rapamycin skin cream. But I will try it at some point, and everybody will see how amazing the cream is when I come back on the podcast. And they're like, wow, you look 20 years younger.
Yeah, exactly. But anyways, I have become a convert. I've taken a course of rapamycin myself. I didn't feel anything. I didn't expect to feel anything. But I think, again, when we start talking about treating diseases way before they happen, we have to really look, to me, at the risk, reward, benefit. And so all the medications I just named, including the rapamycin, really has a low risk when the benefit seems to really be outsized. So, but again, with the rapamycin, that's going to be patient dependent. If someone comes in and they have a terrible quality diet, they're not exercising, they're not sleeping, they're anxious and stressed, and they have no support, and all their biomarkers are in havoc, and they come in and asking for rapamycin, I'm going to say, great, we will get to the rapamycin. But we're going to start working on all these other things that are going to have an outsized impact before rapamycin does.
Yeah, I think that's exactly the right message, and I'm glad you said it that way. Okay, so last question. 5 years from now, what do you hope is standard practice in, I'm just going to call it traditional healthcare, primary care, that right now is only happening at places like Optispan?
I would really hope that there would be much more evidence on preventative and lifestyle medicine. So the things that we're doing, ideally there would be some sort of compensation structure where doctors could be incentivized to keep patients out of the hospital, or how many of their patients have diabetes or not. I know that wouldn't be fair based on where doctors work and, the different patient populations that they have. But there needs to be some sort of a change where we're going to start looking at disease processes before they're happening. We're going to start intervening before someone develops diabetes, before they get hospitalized with a heart attack. We're going to put some ownership on the patient, right? I mean, the big things we always talk about is eat, move, sleep, and connect. And until patients feel like they need to get involved, it's still going to be a reactive model. We can only put on so many medications. So in 5 years, I would love if we could get the government behind this, the local doctors behind this, the patients behind this, and that everyone would really focus on prevention.
Yeah, I absolutely. And I mean, I think in order for that to come about, right, like you said, there have to be sort of public programs in place, or somebody has to pay for it, right? And part of that probably needs to be investment in a wider and more efficient set of diagnostics, biomarkers, right? So like you talked about insulin, right? That needs to be in the core set. DEXA, I would argue, needs to be in the core set that everybody gets. Probably comprehensive hormones at a certain stage of life. So I agree with everything you said. And if people don't know, they don't know what to do, right? And so including that as part of the package so that the doctor and the patient can have, a real discussion around what's going to be the biggest levers they can pull. All right. This has been fantastic. Thank you so much, Nicki, for sitting down and joining me today. We will definitely do this again soon, do a deep dive into the fillers. Maybe if I get my blood test done, we can go through my biomarkers and you can tell everybody what I've been doing wrong and what I've been doing right.
I would actually love to do that. And I won't wear stripes for that discussion.
Okay, great. Thank you so much. And thank you once again for watching the Optispan podcast. As always, if you have any questions or comments, please be sure to leave them below. And if you're not yet a subscriber, hit that subscribe button. See you next time.